Okay.
Yes. Okay. So now within a 10 seconds, audience spread.
So, Doctor,
Saurabh, sir.
Dr. Saurabh, shall we start?
Yeah, sure. I'm ready.
Yes,
Okay.
Trushi, you can start.
Okay. So that's 3, 2, 1. So now we can start.
Good evening, everyone, and a warm good evening and a warm welcome to everyone. At Lupin, we have always believed in nurturing young medical professionals by providing practical guidance and meaningful exposure in the field of respiratory therapy. Skiflix, with this vision, we have introduced Skiflix, a unified digital education platform designed to support upcoming pulmonologists by enhancing their knowledge and making their learning journey smooth and convenient. This evening, it gives us immense pleasure to connect with aspiring pulmonologists through webinar on approach to central airway obstruction. We are honored to have with us respected and eminent speaker, Dr. Sourabh Pahuja. Dr. Sourabh Pahuja is a senior consultant at Amrita Hospital, Faridabad. He pursued his DM pulmonary from one of the India's most prestigious medical institute, AIMS, New Delhi, and holds expertise in critical care and sleep medicine. It is my great pleasure to invite Dr. Saurabh Pahuja to begin today's session.
Thank you, Abhinav, and thank you to the entire team of Lupin for bringing out this webinar series and letting me be a part of the same. So today the topic we have chosen is very fascinating as far as our younger population, as far as our young PGs, postgraduate residents, senior residents, fellows are considered. Nowadays, as we all know, this is not the time when pulmonology is just being practiced with medicines and with your inhalers, nebulizers, and all. Now, people are very fascinating by the word of interventions, which are happening at a rapid pace as far as our branch is considered. Everywhere, you will find one or two interventional pulmonologists working in the hospitals full time dedicated to doing interventions, and that has actually led to enhancement of the branch as a whole also. So just being like a therapeutic person where we just used to give medicines, now we are become a therapeutic interventionist also, where we are doing good work as far as our patients who comes to us with these different tumors, different benign disorders which cause central airway obstruction. So I know this topic is very you can say lucrative as far as the younger population are considered. If I talk about the people who have practiced for 40-50 years, they might not find this a useful topic, but for my younger colleagues, I think so intervention is something which all of us are very keen in learning as well as keen in performing these interventions. And that's why if you see the first slide in my slide, I have mentioned myself as the head of intervention pulmonology. That is because I love this branch so much, and my boss, he gave me an opportunity to head this department of intervention. Although we work as a pulmonologist, we do everything as pulmonologist, sleep, critical care, everything. But again, my personal interest is in the branch of interventions. So that's why I'm heading this department of intervention pulmonology at Amrita School of Medicine and Hospital Faridabad. So without wasting further time, I'll try to wrap up my talk in next 50-55 minutes or so, so that we have at least enough time if there are any questions from the younger minds who are listening to this webinar. So let's see case number one. So my first case is a 45-year-old lady. She's being managed as asthma. Now comes with complaint of breathlessness since she has worsened in the last 1 week, wheezing in the last 1 week, and she says that despite taking inhaler, she is now not responding. On clinical examination, she gives you a finding of right-sided wheezing which is present. Then you do a CT scan, you find something abnormal is looking in the CT scan in the right upper lobe. So practically, although I have not yet here posted the CT film, but in the CT scan, there was something which was obscuring the right upper lobe bronchus and which was causing a ball valve kind of a mechanism, which led to right upper lobe showing you an area of hyperinflation. If you have anything like this in your CT scan, the first thing which you are going to do, especially if the patient is stable enough, you are going to do a bronchoscopy, because bronchoscopies tell you internally which is sitting inside, because sometimes CT doesn't tell you the exact intraluminal contents which are there in the airway and which are leading to this kind of a air trapping mechanism which is seen in the right upper lobe of CT in this particular lady. So this was the video of bronchoscopy. I would like you to focus on the video. So as you can see here in this video, there is left lung which we have seen. In left lung, we have seen the left upper lobe and lower lobe was normal. Then we came into right lung, as you can see here in the right lung. Sorry. Yeah, so we came to the right lung. Right lung, you see easily the middle lobe. You can see the lower lobe, appreciate segments of lower lobe. This is the middle lobe. And when we came and went into right upper lobe, due to such certain trauma by the bronchoscope, there was slight amount of bleeding. But as soon as the bleeding was suctioned out, you can see a lobulated pinkish mass-like lesion is sitting there in the right upper lobe. So this was the exact image where you have a mass-like lesion obscuring the right upper lobe bronchus completely, almost completely, but there was still aeration which was going through the sides of this mass-like lesion, and which led to that bulb mechanism, and which led to hyperinflation being seen in this right upper lobe image when you did a CT scan of this lady. Now coming to another case. So there is a 55-year-old gentleman, heavy smoker, resident of Bangladesh, comes to us with complaint of breathlessness since last 2 weeks, intermittent wheezing for 1 week, cough off and on for 1 week. He was being worked up in his own country. There was CT scan was done, which showed there was a central mass lesion predominantly in the subcarinal area, and the mass was also there in the right middle lobe. Then in view of the same, he was referred to us for doing some kind of diagnostic, as well as, if possible, some kind of therapeutic intervention. When you examine such kind of patients who have this kind of presentation, in this case, he gives us a finding of right-sided decreased intensity of breath sound, especially in the lower areas like infrascapular areas. So let's see the bronchoscopic video of that CT image. I'll show you when I'll discuss the diagnostic part of how you approach a central airway obstruction patient. Here we'll see the bronchoscopic image of this individual. As you can see here, we are at the carinal level. Then we went inside the right main bronchus. In the right main bronchus, there were certain secretions which were suctioned out. And as you can see here, there is an opacity which is sitting here in the right middle lobe bronchus, which is almost completely obscuring the right middle lobe bronchus. Then not just this, if you focus at the side of this, there is another extraluminal compression which is causing almost complete narrowing of the right lower lobe bronchus. So this is right middle lobe opening, where you can see a fleshy pinkish growth completely occluding the lumen of right middle lobe. Then this is an extraluminal compression coming from the posterior aspect of right intermediate bronchus, which is causing this slit-like opening of right lower lobe. As you can see here, this is the opening of right lower lobe, which is hardly visible here, and it is almost completely occluded due to the extraluminal compression. Now comes, is this central airway obstruction? What do you call, or what do you quantify, or what do you nomenclate as central airway obstruction? So central obstruction is basically defined as any pathological condition that lead to airflow limitation, that to more than 50% occlusion of either your trachea, as you can see here in this picture, main stem bronchi, bronchus intermedius, or lobar bronchus. So if you follow this definition, your first case where you had an upper lobe bronchus involvement also fits into central airway obstruction. Your second case in which you have a bronchus intermedius obstruction or intermedius narrowing leading to lower lobe completely, almost completely, opening of lower lobe almost completely narrowed, and middle lobe also being closed by a growth, fits into the definition of central airway obstruction. So this is very important, because labeling somebody a central airway obstruction and then planning further management is actually defined by this. If you have a subsegmental collapse, if you have a segmental involvement, that doesn't fit into the definition of central airway obstruction. And as young minds, we always feel that we should be doing all the things whichever are possible for the patient. That should not be the aim. We should be doing things only when these things are going to give palliative as well as symptomatic benefits to our patient. And practically, for all practical purpose, central airway obstruction, when you are going to treat, should at least include trachea, main bronchi, bronchus intermediate, or lobar bronchus involvement. Then only you should be attempting some kind of a therapeutic interventions in these individuals. Coming to what are the common causes. So again, endoluminal carcinomas like bronchogenic carcinoma, adenoid cystic, mucoepidermoid, carcinoids are very common when they come to you. as a part of endoluminal carcinomas responsible for your central air obstruction. Then a lot of tumor metastasized to the airway. Even lung cancer metastasized to the airway, renal cancer, thyroid, breast. When they metastasize, they again can become one of the important reason of presentation as central air obstruction. Then laryngeal carcinoma, esophageal carcinoma, sometimes even mediastinal tumors. When the tumor are in the mediastinum, which compresses the airway, sometimes extraluminally, sometimes they can even infiltrate inside the trachea and can cause intraluminal compressions also. Then lymphadenopathy, especially from malignancies like above mentioned malignancies can cause a lot of lymphadenopathies where the lymph nodes are so big that they can compress the airway and then they can lead to development of central airway obstruction plus lymphomas. Lymphomas again always is a reason of presentation in terms of an extraluminal compression or in terms of an intraluminal compression. What is this term extraluminal, intraluminal? Why should we be knowing about this thing? Is there any clinical relevance to that? Yes. So if you see this Cotton classification characterizes these things into intrinsic, extrinsic, and mixed. Intrinsic means when the entire opacity, or not opacity, when the entire growth is within the lumen of the airway. So as you can see here in this, the entire growth is within the intrinsic portion or within the internal lumen of the airway. So that is why it is called as intrinsic central airway obstruction. Then extrinsic, when you have a compression from outside the trachea or bronchi or whatever level you have, this is called as extrinsic compression. And then you have a mixed growth where the compression is also there as well as the lesion has infiltrated into your trachea and you can see the lesion internally also. So this is called as mixed growth or mixed classification of central air obstruction. This is important. We are going to see why this kind of classifications have been done and what is the clinical relevance of them in next few slides. Then comes the grade of classification or obstruction. So the grades will be if you have less than 50% obstruction, you're going to call it as grade 1. If you have 51 to 70, you're going to call it as grade 2. Grade 3 is going to be 71% to 99%. And grade 4 is practically there is no detectable lumen present inside. So that is going to be the grade. So again, the more grade you have and the type of malignancy or the type of lesion is going to determine how urgent your intervention is needed and what is the intervention that is going to be done in this particular case. Now, not just malignancies, even benign condition, they also tends to develop central air obstruction. So very commonly you will see is post-intubation tracheostenosis or post-intubation post-tracheostomy tracheostenosis. So again, tracheostenosis can happen due to post-intubation as well as due to post-tracheostomy. Then again, infections like TB causes a lot of stenotic areas, especially young females, left main bronchus or right main bronchus involved. Bronchial stenosis developing in active endobronchial TBs is a cause of concern as far as our country is considered. Although we always say that the incidence of this modality is low. Why? Because we don't always pursue these patients serially, especially when we have a suspicion that a patient has an endobronchial involvement of TB. We should be pursuing this patient actively because once they lose their lung, they come back to you after 6 months and then they have right lung completely gone because of the endobronchial involvement of right main bronchus when the person had an active tuberculosis. Then after that, you don't have anything to offer to them, and the whole life they survive on a single lung. Then again, rhinotracheal papillomatosis, a lot of papillomas forms in them. Then systemic disease like amyloid, Wegener, sarcoid, sometimes even a trauma can present to you with this. Sometimes excessive dynamic airway collapse, malicias can present to you with benign conditions. So again, a lot of benign conditions are also there which can present to you with central air obstruction. But again, this will be predominantly those intrinsic kind of things which will be there in this, or the musculature of the airway will be gone. So as you can see here in these different pictures, you can see this is like a almost pinhole stenosis. This is again a narrowing of the airway. So a lot of kind variant of post-intubation tracheal stenosis can present to you. So there can be circumferential narrowing, there can be a pinpoint opening, there can be irregular granulation tissue formation due to the irritant tube being placed in the airway. And who will develop it? Those patients who have a prolonged intubation, those patients who have a high cuff pressure, traumatic intubation, patients who are on high dose of vasopressors, patients who had required high dose of corticosteroids, patients who are of advanced age. So again, a lot of patients have a tendency that they can develop this. Tracheostomy definitely contains less risk, so that's why PTTS is not commonly seen, which is post-tracheostomy tracheostomy. But yes, post-intubation tracheostomy is more common as compared to post-tracheostomy tracheostomy. again for them there is a classification, because it is dependent on this classification whether you are going to take the patient for a procedure, whether a surgeon is going to take the patient for a procedure, whether just a balloon dilatation is needed, whether a stent is needed, whether a resection anastomosis is possible in this individual or not, or whether this individual can just be observed over time with no intervention being done. So again, they have been classified into simple and complex. Simple is the one when you have one cartilaginous ring involvement less than 1 centimeter in length. When you have multi-level, when you have more than 1 centimeter in length, then definitely the lesion becomes a complex lesion. So again, a complex lesion patient coming to you with symptom needs an active intervention. A patient who comes with a simple lesion with a reasonable lumen of the airway present, you can still observe or you can still plan something electively. Whereas in case of usually complex patients, you are in certain kind of an emergency situation when you have to decide and when you have to do the definitive management as soon as possible. Now, once you are planning to do something, you need to know what all is the area in which I can do all these interventions, plus what all is the scope of things which can go into these areas and can work in these areas. For definitely that part, you need the length, you need the diameter of an airway. Until unless you don't know the diameter and the length of airway, you won't be able to select a particular stent. You won't be able to select the equipment that can go into this area. You won't be able to define what is called as 50%, 70%, 90% if you don't know the basic dimension. So basic dimension of trachea, all of us know, it is 10 to 12 centimeter in length, and the diameter is around 2 to 2.5 in males, and in female it is around 1.5 to 2. Not just the trachea, because central airway obstruction definition includes right main bronchus, left main bronchus. So again, knowledge of these bronchus is important, especially if you are planning an intervention in these patients, and especially if you are planning a stent kind of an intervention in these patients. So again, right main bronchus is 2 to 2.5 centimeter. So you can put a stent in right main bronchus of maximum 2 centimeter, not beyond that. If you place beyond that, then it is going to obstruct the lumen of your, obstruct the opening of your upper lobe, or maybe it's not a right stent to be put in these patients. And the diameter maximum is 15 to 17. So stents come in different sizes, 10, 12, 14, 16, 18. So you can't choose a stent of 18 size in a right main bronchus, especially because the overall diameter of the normal right main bronchus is just 15 to 17. So stent of 10, 12, 14, 16 is, I think so, more than sufficient enough. Similarly, on left side, your bronchus is longer. So due to the long length of the bronchus, your stent size can be from 2 centimeter to 4 to 5 centimeter. But the diameter is 12 to 14. And this narrower diameter of left main bronchus actually predisposes these patients more to develop airway obstruction involving LMB. Because again, the less the diameter of a normal tube, the slightest involvement of that area by some kind of a tumor, by some kind of a benign disease, can lead to stenotic complications or can lead to central airway obstruction in these patients. Yeah. Then comes, how do you assess these patients? So there are certain qualitative things, there are quantitative things. Quantitative, we have already discussed what is the severity of narrowing, what is the vertical extent of the disease, and what is the morphology of the disease which we are talking about. Among the quality, you need to know what is the mechanism, what are the dynamic features, and what is the histology of thing which you are dealing with. A benign histological thing, you can try to achieve a complete cure, whereas a malignant histology, you won't be achieving a complete cure. So coming to certain good practice guidelines as far as these management of central airway obstruction patients are considered. So the good practice guideline says that your comprehensive history and physical examination is the most important thing when you have a patient in front of you who has come to you with central airway obstruction. Not just because the history is going to tell you, a patient comes to you in distress, in your emergency, gives you history 2 months back, he was on ventilator for 15 days. You come immediately, you come to know that there is a possibility he might be suffering from post-intubation tracheal stenosis. A person already a known case of CA esophagus, not able to eat, undergoes a esophageal stenting. Now comes to your emergency with complaint of distress, dyspnea, stridor. Possibly that stent in the esophagus is compressing your trachea. A person of CA esophagus undergoes radiotherapy, already had a high up lesion. As soon as radiotherapy is done, the patient presents with stridor in distress in emergency. Probably radiation induced increase in the size of the tumor, which happens for first few days, has led to a significant airway collapse. So again, these are things which need to be known to us when we are dealing with these patients, because again, they are going to let us know what further intervention is going to be required in this particular patient. Then physical examination. A person comes to you tells you I have wheeze, taking inhalers but no response. But you auscultate him, there is wheeze only on one side. So this is preferentially a mechanical thing which is causing this wheeze rather than an obstructive airway disease causing a wheeze. So again, physical examination is equally important as far as these patients are considered. Then comes CT scan of the chest. If a person is stable, if a person can undergo a CT scan, do not attempt intervention before doing a CT scan, because CT scan is going to give you tons of information about the histology, not about the histology, about the etiology, about the area of involvement, type of involvement, level of involvement, and what definitive intervention has to be planned should be done only after CT scan. Only in desperate situation when your patient is not fit enough to undergo a CT scan, you might try seeing it with the help of a bronchoscope. But again, in rest all situation, you should be considering a CT scan as a prior modality before taking your scope and before going inside the patient. Then again, certain lab investigations, preoperative assessments are required. A patient should not have cardiac issues. A patient should not have significant blood sugar derangement, significant hypertensive issues. So these issues have to be taken into consideration because these interventions are going to be challenging as far as a patient is considered. So again, history is going to tell you a lot of things about the possible cause, progression of the disease. Yes, in history, a significant history is when a person is wheezing and is not responding at all to bronchodilator, is something which gives you a clue that there is a possible element of airway obstruction, which is there, a mechanical airway obstruction, which is not responding to your bronchodilators. Now, clinical presentation depends on what is the level of obstruction, what is the amount of obstruction, and what is the overall clinical status of the patient. A person comes to you healthy with certain amount of dyspnea, certain amount of wheeze practically in the left lung, and you find that there is decreased intensity in the left lung only, but otherwise right lung is ventilating fine. So then that person, because of his build, because of the limited area, is not having that much symptoms. A person comes to you with a tracheal tumor compressing almost 80% of the area, already a frail patient, will definitely be having more symptoms as compared to the first one who was having just a left main bronchus involvement and with good body strength. Again, your clinical presentation depends on how acutely the disease has come. A kid come to you with a foreign body inside. Definitely this is an acute presentation. Whereas on the other hand, a CA lung patient comes to you with chronic symptoms of COPD, now presenting with stridor or dyspnea, is a person who has a slow growing disease which has led to this. Then again, the presentation depends on their underlying general status also. Like if somebody is having a cardiac issue, he might not be able to tolerate this much amount of hypoxia which is happening in him as compared to a person who was reasonably fit. Then again, a lot of anxiety issues are there with these patients which bring them to emergency with even a small amount of dyspnea being perceived as large. Again, physical examination, as I told you, is very important. Unilateral wheeze, distress, orthopnea, signs of collapse, which we see when we are doing our routine case presentations. Like there is an area of the lung which has impaired node, which has decreased intensity of breath sounds, which has rib crowding. So again, these are few of the things which tells you, okay, there is a possibility that there is a collapse in this area. And this collapse could be due to an endoluminal thing which is causing airway narrowing. Plus, an important thing, especially for the younger minds who goes to emergency, who is the patient or who are the first contact of these patients, is that if a patient has come to you with breathlessness and this patient is having a stridor and you are giving them non-stop nebulization and oxygen, but they are not responding, most likely you are dealing with the patient who is having a mechanical obstruction. This is very true if your patient of hemoptysis comes. This is very true if your patient of foreign body aspiration comes. This is very true if your patient of obstructive air or airway obstruction due to malignancy or benign disorder comes, that you give them oxygen, they don't respond because in them, until unless you are not going to take care of that mechanical part, they are not going to respond. Now, if you have a subacute presentation, you can do chest X-ray, CT, dynamic CT, you can do even virtual bronchoscopy where you convert a CT into a bronchoscopic image and see the airway. You can even order a PFT also. But in case of acute situation, when a person comes to you acutely, when you don't have the time for CT, try to get a CT, or if feasible, can get a CT. But if you are not able to get a CT, the first and the most important priority in this situation is to secure airway, even if it comes at a cost of intubation. But if you are doing or if you are planning to intubate a patient, try to do it bronchoscopic guidance because there might be a tumor which is sitting in the trachea. And as soon as you try to pass the tube, you are stuck, your tube is not going further. So again, in these situations, sometimes having a bronchoscopic vision while intubating or while securing the airway is the biggest blessing which we can have while we are handling these patients in our ER. Again, flexible bronchoscopy, rigid bronchoscopy, anything can be selected. It all depend on your expertise, upon your availability, and upon the general condition of a patient. So a patient collapsing in front of you might not give you a time to put a rigid. In that situation, you might just need to take a flexible bronchoscope, guide a railroad endotracheal tube onto it, and then you can go inside and see what is happening, and then try to at least secure the airway. Maybe if there is a malignancy in the left lung, you can just secure the tube in right lung. Maybe if there is a bleeding in the right lung, you can secure the left lung. Maybe if there is a narrowing in the trachea, you can pass your bronchoscope and then you can push through your tube. Sometimes not even a standard tube, you have to select smaller size tubes also for at least securing the airway, because that is the primary aim. And after that, you can do CT and whatever. After that, you can plan your definitive intervention. Coming to CT, CT shows pictures like this, CT shows pictures like this. So always when you are seeing the CT of your patient, your aim should be not just to see the parenchyma. Your aim is to see the lumen of the airway also. In my unit, I am always being told that whenever you see a CT, like whenever I see a CT, I always focus on the airway first. And I think so that approach with me, because I am fondly interested in intervention pulmonology. So that's why my always aim is to see these airways. And sometimes even there have been instances when I have picked up certain things in the airways which even my radiologists have missed because of the routine habit of seeing only parenchyma and predominantly parenchyma. Then I have told them, okay, boss, there is a narrowing which seems to be there. There seems to be some thing inside the airway. And then they have cross-checked, and then yes, they have come up with the answer. Yes, the boss, there is certain kind of a narrowing, certain kind of an involvement in the central airway also. So again, as you can see here, these are missed by a radiologist in 31% of the cases. So again, if you are an intervention pulmonologist, a dedicated intervention pulmonologist, you need to see your scans yourself thoroughly. Yes, you can go there, discuss with them so that you become more wiser. And for planning your procedure, it is absolutely essential and absolutely must that you should be doing this kind of airway assessment. So as you can see here in this picture, airway is narrowed. As you can see here in this picture, LMB is narrowed. So again, this gives you an idea, okay, this much is the segment which is narrowed, this much is the level at which there is narrowing. And then depending upon the area, depending upon the involvement, you can go and you can decide. So as I told you, there was a patient from Bangladesh in which we saw there was a right middle lobe growth as well as a central mass. So let's first see the CT of that. So I told you that I'll be showing you CT in the later slides. I'll showed you the bronchoscopic vision, but again, CT is very important as far as this patient is considered. Yeah, I'll just scroll through it myself. Yes, so as you can see here, there is a whole huge mass which is seen in the central area, and there is a portion of the mass in the middle lobe also. Going up further, as you can go up further, yes, this whole mass is involving the subcarinal area. This is the right main bronchus, this is the left main bronchus. As you go, you can see, yes, up. So you can see, yes, right upper lobe bronchus opening is almost patent. Right main bronchus is almost patent. Left side, there doesn't seem to be any compressive effect on the left side. But if you go slightly down in this case, show it from the beginning, yes. Yeah, so just focus on right main bronchus, yes. Right main bronchus, upper lobe uptake has already done, then intermediate bronchus going down, 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 and yes. Here, almost intermediate bronchus is completely collapsed because of the extrinsic growth which is sitting in this case. So the CT told us that there can be a possibility that there can be an extrinsic growth in this patient. But when we did a bronchoscopy, in the first video which I showed you, that Bangladeshi patient which I showed you, in that video you would be able to appreciate that yes, intermediate bronchus was pushed by an extrinsic growth, but again there was an endoluminal component also in the right middle lobe. So again, bronchoscopy is must again as far as the airway assessment and the internal structure of the patient is considered, but CT gave you a heads up that you are going to find something abnormal in the right intermediate bronchus and maybe possibly at the level of right middle lobe bronchus opening. Spirometry, people have been fond of telling us and teaching us about. Our teachers have told us that in spirometry you can pick up an airway obstruction, but it can only be done in subacute presentation. And there are particular flow volume loop which tell you or which gives you an insight that yes, this is a particular patient who is having a central airway obstruction or a fixed airway obstruction. So this kind of loop you can see here in this picture, a fixed airway loop in which you have a box-like presentation. is something which can be seen as far as a part of fixed airway obstruction or central air obstruction is considered. But again, important thing, it can only be done in subacute presentation patient, not in a patient who have come to an emergency. Let's just excuse me for a second. So important thing is you should know which tool you have to use at what particular position you have to use that tool. Then coming to diagnostic bronchoscopy. Diagnostic bronchoscopy tells you the diagnosis, tells you the endobronchial involvement, tells you the patency of the distal air. Very important when you start your journey as an intervention pulmonologist. You will be very fond of treating every patient who comes with a central air obstruction. But there is an important aspect. Always see distally. If the distal airway is not patent, what are you going to achieve by putting up a stent? What are you going to do by doing a central airway tumor debulking? If distal airway is not patent, if the lung has collapsed for long period of time, if the lung has become bronchiectatic, there is very less likely a chance that you will have a good successful outcome after doing such a major intervention. So patency of distal airways is always the first thing which should be assessed before proceeding or before jumping for these interventions. You might see a lot of people now doing for completely collapsed endobronchial TB patients a lot of interventions in helping them open up the airways. Yes, that can be done, but again, for that, one thing which is still needed is patency of the distal airways and the time till which this collapse is there. If it has been there for years together, you won't be able to get anything. Yes, if it has been a recent event, you can definitely try for it. But telling you from my own personal experience, handling these patients who do not show you a patent distal airway, doing some kind of an intervention, doing balloon dilatation, even with Fogarty, CRE balloon, even with trying to do some kind of an electrocautery incision knife use in these cases is going to be a risky job, especially when you are beginning your practice as an intervention pulmonologist. Yes, when you have established yourself, then you can be brave enough to take these kind of chances, especially for those patients whom you have no airway visible after your obstructive area. But again, this should only be tried when you are an expert and when you have already established yourself and your center has the expertise for everything. If anything goes wrong, you have an availability of an ICU, you have an availability of a thoracic surgeon, which is helping you out in this situation. So if you see, diagnostic bronchoscopy told us that yes, there is an aspergillus tracheobronchitis. Diagnostic bronchoscopy showed us there is a tumor in the airway. Diagnostic bronchoscopy showed us that there is an endobronchial TB involvement in the airway. So until unless you don't do a diagnostic bronchoscopy, never an intervention should be planned. It should not be your aim that I'll directly take the patient to OT and then I'll do a bronchoscopy and then I'll decide what needs to be done. If you are doing a bronchoscopy, if you find tumor in the airway, you know that you need things to be managing the tumor like cautery, cryo, APC, and all these things will be needed. If you know there is an extensive compression, which you have seen, there is no endoluminal involvement, you know you just need a stent. Then you might need fluoroscopy, you might need a rigid bronchoscopy. So again, a lot of things are needed as far as different cases are considered. But again, it depends on what you have seen, what you have found with the help of your bronchoscopy. Coming to the role of therapeutic bronchoscopy, yes, this is what the intervention pulmonologists tend to do. They relieve the patient of their airway obstruction. They improve their performance scale. Now, our oncology colleagues have understood, and still there are a lot whom we need to make them understand that yes, if your patient has come up with a poor performance scale, and that is due to the central air obstruction, giving the patient first to us or sending the patient first to us and then letting us do some kind of an intervention will improve their performance status if it is due to this thing only. And yes, if it is a good performance status post your procedure, they can definitely be considered for radiotherapy. They can definitely be considered for chemotherapy. Sometimes in certain kind of tumor, like in carcinoid, like in benign tumors, it is curative. You cure the patient of their disease by just taking care of the endoluminal disease which is present in these patients. Now, the most and the biggest concern when you do an intervention is whether to intervene or not to intervene. In the initial few years, when you're practicing, your aim would be to intervene in everyone. Not aim, you can say you will like to intervene in everyone. But as a established intervention pulmonologist, you should know that when not to intervene because anything can go wrong. There can be even on table death of a patient if you have not thought of these things prior hand. Plus, when there was no need to intervene and you have tried to intervene in these patients. So again, if the airway obstruction is the likely cause of dyspnea, you should intervene. If the distal lung is expandable to obstruction, you should definitely intervene. If the type of lesion is extrinsic, stenotic, exophytic, what is the bleeding risk? This all should be known to you before intervening, and then it will decide what intervention has to be done. Duration of obstruction. Patient coming to you with a post TB sequelae. 10 years back he had TB, had a destroyed left lung. Do not intervene. 10 years, since 10 years, this lung has been destroyed. This lung would have become bronchectatic till now, or would have become dead till now. So there is no point of opening up such lung. Yes, a patient with active TB comes to you with just 2 months history of ATT, with just 2 months history of symptoms, coming to you with the left lung collapse. Yes, in these patients, a definite attempt should be tried, because again, these are the patients in which you can have a successful outcome also, because it's just been 2 months or just been a few months since this patient has this kind of an obstruction. Again, mean survival. A person who is likely to die with malignancy in next 15 days, what is the point of intervening? But there is a patient in whom a chemo, radio, or whatever therapy can prolong his life to 2 to 5 years. Definitely an intervention should be done in these patients. Then, depending upon response to the tumor, if there is a patient who has 50-60% of obstruction due to a small cell carcinoma, and you know that small cell carcinoma responds very beautifully to chemotherapy, and the person is not that symptomatic because of their obstruction, you can still wait in this condition. Let the tumor show some kind of a response. But yes, if you have a squamous cell carcinoma, if you have a carcinoma which is not going to be very responsive to a chemotherapy quick quick duration, then in that situation, if the person is symptomatic, if he has something like this, try to give them an interventional modality, do some interventional modality, so that you can relieve them of their air obstruction till the time the patient can undergo the chemotherapy, which is again the definitive treatment for these. Chances of future surgery, benign airway obstruction. If the person is being planned for a future surgery like resection or anastomosis, why do you want to put up a stent? Just do a balloon dilatation and just come out, and just let the patient be okay till he gets a surgery. A patient who is not a surgical candidate, where surgery has been deferred by the surgeon, by the patient, or whosoever has deferred the surgery, then in that situation, doing an intervention like, especially for benign, doing a stenting like an intervention should be a beneficial thing as far as patient is considered. And most important is functional status of the patient. If a patient is very weak, you know that this patient is not going to survive the general anesthesia which you are going to give, do not intervene in these patients. Do not have that key, okay, don't want to lose any of my patient. Yes, let the patient go, because post intervention, if you land yourself or your patient into a complication, that is the biggest trouble for an intervention pulmonology, and that thing is going to be there with you for years together. So again, always choosing whom not to intervene is more difficult as compared to choosing whom to intervene. So again, therapeutic bronchoscopy, as far as these patients are considered, should be an adjunct to systemic therapy. So this should be told to our oncology colleagues also, that yes, there is a need of a therapeutic bronchoscopy along with the medical therapy and along with the radiation therapy as far as patients are considered. Now comes the most important aspect, pre-procedure counseling. I think so. The most important slide in this entire presentation is about this topic, which is pre-procedure counseling. Always discussed what should be the outcome and what should be the expectation. Don't show them too much of a gloomy picture that yes, everything is going to be good. Tell them what all can happen. Tell them what is the procedural success. Tell them what is the complication rate. Tell them what are the mortality rates with this intervention. Until and unless you have not done a detailed pre-procedure counseling, do not take your patient up for a procedure until it's an emergency. Like if somebody has come with stridor in emergency where you don't have that much amount of time. Before that also, always save yourself. And saving yourself is only going to be done when you are doing a proper pre-procedural complication, because people have been stuck in situations where their patients have gone onto ventilator, remained on ventilator for months together. Then people have also lost their patients while on table or post these interventions. So again, all these things have to be told to the patient. If they are already a high risk patient like kidney disease patient, poor nutritional status patient, diabetic patient, cardiac patient, they should always be told about the risk of anesthesia and about the risk of interventions which are being done in your patients. Coming to what are the therapeutic bronchoscopic interventions which are available with us. Now you can do a rigid bronchoscopic intervention, you can do mechanical debulking, where you with the help of a rigid bronchoscope debulk the tumor. You can do thermal ablation, you have electrocautery, you have APCs, you can do stenting in the airways, you can do cryotherapy, you can do even balloon dilatation. But again, this slide shows you there are 6-7 types of interventions which can be done. Which one to be chosen for whom? Let's see. in the upcoming slides. So choosing an option among these depends on the type of lesion. If you have an intrinsic lesion, you are going to do some kind of a debulking because there was a tumor inside the airway. You debulk that tumor and your patient could be relieved of its symptoms. If you have something which is compressing from outside, you need a structure which can remain, which can keep the airway patent. So you need something like a stent where the airway can remain patent because of this extrinsic compression which is happening. Then it depends on the operator experience, whether you are going to do a rigid bronchoscopic guided tumor debulking. You take your rigid bronchoscope, you mechanically core the tumor. It depends on your operator. If you are not confident in rigid, do not try it with rigid. Try it with the flexible bronchoscopic guided interventions. Available expertise. If you don't have that available expertise, you should not be trying with those modalities in which you are not expert at. Patient prognosis. What is the prognosis of the patient? If the patient prognosis is good, you are going to try to achieve as much as palliative procedural success as you can. Then again, if the patient is able to tolerate that selected procedure. Again, if the patient is not able to tolerate a rigid bronchoscopy, you should not be giving them rigid bronchoscopy. If the patient is not able to tolerate a stenting procedure, you should not be trying for a stenting procedure. To summarize what should be done in what, this is the easiest slide. You have a patient who has symptomatic malignant airway obstruction. Endoluminally, try therapies like laser, APC, cautery, cryo, mechanical debulking. These are the things which give you immediate effect as far as an endoluminal component is considered. But there are therapies like cryotherapy in which you have a late or delayed effect as far as effect is considered. So with cryotherapy, if you have an endoluminal component, you can attach it and you can just break it down and bring it. But again, photodynamic therapy, brachytherapy, these are things which has a slow onset of action. Extraluminal thing, either try to dilate it. If it remains dilated, job done. If it doesn't remain dilated, put a stent in the airway if patient fits into the category of putting a stent. Now comes the biggest question, because not all of us are blessed to have rigid bronchoscope. Shall we do it with rigid bronchoscope? Shall we do it with flexible bronchoscope? Oh, that particular person is doing it with flexible bronchoscopic guidance. Oh, this particular person does every case in rigid because he has a rigid. I think so. There is no right or there is no wrong to this thing as far as the choice of scope is considered. It all depends that in your patients who have rigid bronchoscopy can be considered for doing all these interventions. So rigid bronchoscopy helps you in putting silicone stent. In case of silicone stent, without the help of rigid bronchoscopy, you can't put a silicone stent. That is a dictum. So you need a rigid bronchoscopy if you are planning a silicone stenting. But with self-expanding metallic stent, people have even done this with the help of endotracheal tube, with the help of flexible bronchoscopy alone. Now there are through the scope stent which can go through the scope into those areas and can do the defined job. So again, there are advantages with some, there are disadvantages some. With rigid bronchoscope, the advantage is lumen is large, multiple instrument can simultaneously pass, ventilation oxygen can be done. You can isolate each of the airways. Suppose if left airway starts bleeding, you can isolate the right airway, putting or passing your rigid into right. Prolonged procedure can be done. You can have a deep sedation. You can even use a muscle relaxant if you are doing a rigid bronchoscopy, so that your patient is not disturbed by doing those interventions. Plus, you have a good control on the airway of the patient. With flexible bronchoscope, again, the ease of doing it in emergency is something which is good. Minimal sedation, if a person is not a fit candidate for general anesthesia, can give you a good outcome with flexible bronchoscope. But again, practically, flexible bronchoscopy should be reserved for sampling of the airways, for airway assessment, and for a procedural planning. Majority of the patients in whom you want to do, the recommendation says that rigid bronchoscopy should be preferred over your flexible bronchoscopy as far as these therapeutic interventions are considered. Then comes sedation. People say that we just do it with help of a just plain bedazolam. We even don't give midazolam. We just do it with the help of fentanyl. Here you are talking about a therapeutic central airway obstruction management. So in these situations, always try to prefer general anesthesia, or if not general, then a deep sedation over your moderate sedation or light sedation, because in these interventions, you want a good control of the airway. Now, after listening to all of this, let's see which approach should be applied in which particular case. Here there is a 55-year-old lady. Last year was referred to us with worsening shortness of breath for just 2 weeks. And she says noisy breathing is there for 1 week. Referred in view of no response to therapy like bronchodilators and all those things were given, but there was no improvement. Came to emergency, 2 o'clock at night, was having stridor. Now, I am although showing you the rigid bronchoscopic video of this lady. CT scan done in the emergency showed that there is something sitting inside the trachea which is causing 70 to 80% luminal involvement in trachea. The lady was in distress, so the lady was shifted to ICU where she was kept on NIV the whole night. Somehow she was managed with that modality. Next morning, as she was still very dyspneic and CT was done hardly, with the help of NIV, showed us that there is some kind of a tumor which is sitting inside the right main trachea, in the main trachea. So it was decided, okay, let's just take this lady up directly for a procedure. She was taken up into OT. But again, before passing the rigid bronchoscope, what we did was did a flexible bronchoscopy. We asked the anesthetist to put an LMA. Through the LMA, they were able to ventilate that lady. And through the LMA, we did first a check bronchoscopy of this lady. And then post-check bronchoscopy, when we were confident enough what is the diagnosis, we decided, okay, now we'll proceed in this particular manner. So I'm showing you the video of the rigid bronchoscopic guided flexible bronchoscopy. A lot of us are always confused when we use a rigid bronchoscope. Can we use a flexible bronchoscope? Yes, rigid bronchoscope is just a conduit. With the telescope of rigid bronchoscope, you just place your rigid bronchoscope inside the airway of a patient, and then all other interventions are being done with the help of flexible. So as you can see here in this video also, this is the rigid bronchoscope barrel, and the camera which is going is actually the camera of the flexible bronchoscope which you have passed through this rigid bronchoscope. You can see here almost 70 to 80% luminal narrowing just above carina with a pink fleshy growth present in the lower end of carina. So now, how should we achieve airway patency in this case? You have an endoluminal disease, you don't have an extensive disease. You can consider directly debulking of these tumor. Now it can be a cryo debulking, it can be a mechanical debulking, it can be debulking with the help of hot therapy, laser therapy, anything can be used. Even a brachytherapy, somebody might be able to use a photodynamic therapy, intratumoral chemotherapy can be done as a part of airway as a part of airway patency achievement. So mechanical debulking, when you take a rigid bronchoscope, the barrel of rigid bronchoscope engulfs this tumor and goes through this tumor. So you mechanically erode that tumor, that is called as mechanical debulking. Then comes endobronchial electrocautery, or somebody calls it at hot therapy. So in hot therapy, you can use a snare where you can loop the tumor and then just remove the tumor. You have options of hot biopsy forceps, where with the help of electric currents being passed into this biopsy forceps, you can take bite by bite of that tumor and just keep on doing till you have achieved a significant luminal patency. And then these are electrodes which coagulate the surface of the tumor and burn the surface of the tumor if you know that this tumor is going to be a vascular tumor. But again, this procedure also takes a lot of time. With the help of this electrode, you can burn the tumor, and then again the burnt tumor you have to remove with the help of a biopsy forceps or with the help of a cryoprobe. APC. All of us know that APC is a modality which has to be used when there is a tumor or when there is a bleeding inside the airway. APC is a superficial modality which coagulates the superficial bleeders which are present. Per se, APC is not very useful modality for debulking a tumor. But yes, if there is a bleeding which is happening, you can choose an APC. Laser, definitely a better modality, can churn off or can burn your entire tumor, and then the burnt tumor you can easily pick up with the help of biopsy forceps or with cryo. But again, the availability of laser is something which is not there with all of us. Then comes cryotherapy. Cryotherapy has come up in a big way as far as airway interventions are considered. We are doing mediastinal cryobiopsies, we are doing airway tumor cryobiopsies for diagnostic purpose. But is there any role of cryobiopsy or cryotherapy in therapeutic procedures? Yes, there is a role. I'll show you how cryotherapy helps in our cases. So let's see this case where I showed you a tumor was there in the lower end of trachea, how a hot therapy helped us and how a cold therapy helped us. So cryo is also called as a cold therapy. As you can see here in this picture, the tumor was there. Running the video, yes. Now you can see here we have chosen a snare. So you can see this is the wire of the snare which we are trying to loop around the tumor. So we used a biopsy forces simultaneously also, as well as a loop also to just, as well as this snare also to loop this tumor with the help of this snare. Once the tumor was looped completely, then you actuated the snare. After actuating the snare has a modality that it cuts as well as coagulates the tumor. And after say 1 or 2 minutes, you were able to cut the entire tumor from where you have hold it. Although you were not able to see it because we can't simultaneously go into the distal end and can see where we have hold the base of the tumor or not. But practically for those tumors who have a base, you try to hold the base with the help of this snare. and then you cut the base. As you can see here, the tumor got cut and then the tumor started moving. So you can see here in this picture, now the tumor has started moving, which was fixed at the lower end of trachea. Once you know that tumor has started moving, you have significantly cut the, or you have significantly removed the entire tumor from the base, or whatever portion you were able to remove. Now in this situation, how to remove this? As you can see here in this picture, now the tumor has gone into the right main bronchus, because you can see here it is movable. This is the base of the tumor which you are able to see, and this is the tumor which is in the right main bronchus. Now this probe here which has come up is a cryo probe. So you can hold the tumor with the biopsy forceps, but what happens is majority of the time when you are trying to pull it out, biopsy forceps will take a biopsy piece and then will come out. But again, the help of cryo in bringing out this tumor is a useful modality. As you can see here, the cryo probe went inside, cryo probe froze the tissue along with it, and then in the frozen modality only, you can see here the whole tissue can be removed in one go. And yes, we were using a rigid bronchoscopic conduit to do all this kind of intervention. And now, sorry. And now here you can see, after debulking, we decided to ablate the base of the tumor. So the base of the tumor was ablated with hot therapy with the help of APC, with the help of electrocautery. And we could achieve almost complete patency of the airway with the base of the tumor also burned with help of APC as well as with the help of electrocautery. Now let's show you how APC helps in this situation. So here electrocautery and APC was used to just take care of the base. Now here you have a tumor which is coming up, arising from the right upper lobe, projecting into the airway lumen. You decide to, okay, do some kind of debulking. You decided, okay, why not just take a snare? But this was a broad-based tumor. Until unless you don't know the base of the tumor, your snare is not going to help you out. So you can see here, the snare was tried to be wrapped around this tumor, but yes, we were not able to wrap around the snare for this tumor. Then coming forward, we decided, okay, somehow we have to start debulking for this tumor. We decided, okay, why not use the biopsy forceps, especially you can see here multiple attempts are failing as far as this. So this is a hot biopsy forceps where you can see it is charring the tissue also by passing the electric current, and it is taking piece by piece the tissue also. So yes, we started doing it. It takes a lot of time because again, it is a slow modality. And the benefit of using a hot biopsy forceps is that it ablates the tumor as well as it coagulates the basic vessels. But again, despite using this modality, there was a bleeding which started happening. In this situation, you are supposed to first stop the bleeding before attempting further intervention. And can any modality help you out? Yes. So this is an APC which came to a rescue where we decided to coagulate these superficial vessels. Per se, APC doesn't do significant debulking. It only coagulates the surface of the tumor where you have an active bleeding. As you can see here, argon gas is being passed, and this coagulation helped us in controlling the bleeding. And after the control of bleeding, we again started commencing with the debulking part which we are doing. So coming to cryo, we have seen cryo helps in central air obstruction by removing the tumor, which you have already avulsed with the help of your hot therapy. Sometimes some people even do a cryo biopsy, not cryo biopsy, cryo probe guided debulking, where they take the cryo probe into the tumor, which they are not able to remove with the help of a snare. They keep on taking bigger chunks of that tissue, so that that tissue within maybe say next 20-30 attempts can be removed completely. But there is always a problem. If you avulse a tissue with the help of a cryo, there is always a chance that there can be a bleeding. So what we commonly prefer is we first prefer to use a hot therapy, ablate the tumor surface, or try to remove the tumor entirely from the base, and then use a cryo biopsy. But again, not just it is about tumor. There are certain other modalities in which cryo can help you, and they can also present to you with a central air obstruction. So clot extraction. Clot in an airway is a central air obstruction. Where there is a gentleman in the transplant ICU presented with hemoptysis. Then when we went inside, saw that left lung was completely occluded by a clot. Tried to suction it with the help of a bronchoscope, tried to remove with the help of a forceps, were not able to. Just only small bits were coming. So you tried to use a cryoprobe in this situation, froze the entire clot in one go, and within a span of hardly 30 seconds, the entire clot you can see here in this picture came out, and patency of the airway could be immediately established. So cryo not just is a useful modality as far as a tumor is considered, it is a very useful modality when you have a clot extraction. And if you have an organic foreign body, as you can see here, this is a kid who is just 7 months, came with a peanut aspiration, had an organic foreign body, trying to hold up with the biopsy forceps, and that too very small biopsy forceps was making it very difficult because there was bleeding in the surrounding area due to the biopsy forceps. So an attempt to hold this foreign body with the help of a cryoprobe was taken. And as you can see here in this picture, cryoprobe could hold the organic foreign body in one go. And yes, in one go itself, the foreign body could be brought out and child could be relieved from its misery, which he was suffering since last 48 hours. As you can see here, cryoprobe holding it firmly, just keeping the paddle of the cryoprobe pressed, can easily brought out this modality. And you can do it with the help of a flexible bronchoscope only, and you can do it with the help of an LMA only. You don't need rigid bronchoscope, you don't need a bigger size of things. You can easily go via an LMA, take your flexible bronchoscope there. Your cryoprobe goes through the lumen of your flexible bronchoscope. So again, if you have tumor excision, tissue excision, they should be definitely tried as far as a part of endobronchial disease are considered. Endobronchial diseases, try to ablate, try to debulk with whatever modality you are confident in. Coming to another case. Now there is a 45-year-old male, comes to your emergency, gives you a history that past history of mechanical ventilation is there. Shortness of breath is there for 1 week, and that too it is for more on lying down. Visited a nearby practitioner in view of wheezing, was given nebulization, oral bronchodilator, but there was no response. Chest X-ray was done, which was reported to be normal, because in chest X-ray in such a patient, you might not be able to see something inside. Then the patient underwent a PFT. PFT showed that a box-type pattern of involvement was there. So yes, there was an suspicion for a fixed airway obstruction. Then the patient underwent a CT. CT showed that yes, the patient is having some narrowing in the mid-tracheal level, where the airway lumen is hardly 10 to 20%. So in emergency situation only, after doing CT, with the available PFT which was done outside, the patient was planned for a flexible bronchoscopy. And this was the flexible bronchoscopy image at the upper or mid 1/3 tracheal level, where you can see a lot of webs, where a lot of adhesions, a lot of features are there, which is comprising the lumen of the trachea to hardly 20%. And this is the now video of that particular individual. Yes, so mid-tracheal level, concentric narrowing at various levels. And at this particular level, you can see 2 or 3 cartilages are involved. Plus, at this particular level, a complex disease has been found. Now comes what should be done. You have to achieve the patency of the airway. You can consider putting a stent in this kind of an airway also. But practically, first you should have to achieve at least a bare minimal patency. So for that thing, like there are webs, even if you try to do a balloon dilatation, they might fail because these webs are not going to be broken with the help of a balloon. So you need something which can cut through these webs as far as this airway is considered. Yes. So you can see this is an electrocautery knife which you can connect with the same electrocautery machine with the help of which you are doing rigid bronchoscopic and with the help of which you are doing this coagulation part. So as you can see, as soon as the webs are cut, you were able to at least pass your flexible bronchoscope through this lesion. Then you decided to do some kind of a balloon dilatation. So a balloon dilatation was also attempted in this patient. With the help of balloon, you can try to enhance the area. Then now cryo also has a role as far as these patients are considered. They say that a relapse of the disease can be prevented in these patients by doing a cryo spray in this area, which is the actively involved area or actively inflamed area. But again, this is a trial which is going on. So a lot of us do after debulking, after achieving significant luminal patency, try to do the devitalization of the tissue with the help of cryoprobe. So again, role of APC, no. Role of electrosurgical knife, yes. And cryo, yes, we have seen the role of cryo also. How to prevent relapse? People have tried mitomycin C, people have tried cryo, but again, there is no such recommendation which tells you that this, in this situation, only this can help. Then comes in case of non-malignant lesion, benign lesions, when you have stenosis, airway dilatation should definitely be performed. Yes, you can perform it with other therapeutic modality, like in this patient we have seen, we have used an electrocautery knife, we have used a cryo also. In certain situation, some patients might be posted for a stenting also, but again, that depends on the etiology and that depends on the surgical feasibility of management. If a patient is not surgically manageable, or if a patient denies surgery, or if the surgeon denies surgery with a very high risk, then in that situation, a stenting like option should be considered for these patients. Now coming to another case, a lady who came with being ventilating because of the central airway compromise. This was due to tumor which has led to all the problems. Now this is the CT of that lady which was done in emergency, because now the lady was ventilating fine with the help of a tube. CT gives you at least a pre-procedural planning. As you can see here in the CT, yes, as you can see in the CT, yes, the lumen of trachea is almost narrowed. There is some intraluminal thing which is present inside the lumen of the trachea, but remaining bronchus was almost normal, and there was a left lower lobe collapse also which was sitting there. Going to further part of this video, when bronchoscopy was done, it showed that yes, the peripheral areas are okay, but the central area had a intrinsic growth which was occluding, plus there was some component of an extrinsic growth also. So this was a mixed lesion in which both the things were there, extraluminal also as well as intraluminal also. In this situation, as you can see here, if you focus on this part, this is such a difficult lesion to even debulk also, that you won't be able to debulk such kind of a lesion when the lesion is just on the anterior aspect of your tracheal wall. So in certain kind of situations like this, when you have extraluminal as well as intraluminal component, rather than just going ahead with the debulking, you can easily put up a stent, because again, stent is gonna take care of the endoluminal component also by pushing it towards the wall. So in this patient, we decided to put a stent, and when doing the stenting, there are different approaches. You can use a rigid bronchoscope, you can use a fluoroscope, you can just do it with the help of a flexible bronchoscope, with the help of through the scope. We at our center prefer to do it under rigid bronchoscopic guidance. This was a Y stent, so we chose a rigid bronchoscope of a bigger barrel. Then through that, we decided to put up a stent, and then a stent was placed in her case. And post stenting, she was able to be extubated on table in the same setting, and post that part, she was able to go home without being on ventilator. So again, what is an ideal stent? A stent which is easy to insert and easy to remove. It should fit and it should complete your need. It should be of a material which should not irritate the patient too much. And it should be economically affordable. But I say an ideal stent is a stent which should not be put. Or if I modify my word, an ideal stent is the stent which you can put, but will be able to remove later once the patient is already cured of the illness which was causing that kind of a central air obstruction. So again, metallic stents, silicone stents, these are different stents which are available with us. Depending upon benign disorder, malignant disorder, you can choose. You have bronchial stent, you have those tracheal stents, you have tracheobronchial stents. So a lot of different kind of stents come. And this all depends on your pre-procedural planning, which stent you are going to be needing in this particular intervention. Now again, just another last case of a benign airway stenosis where a patient with post-intubation, post-tracheostomy developed a stenosis like this. Patient was given a trial of balloon dilatation, failed. After that, patient was posted for a surgery, but the surgeon was not convinced in doing the surgery because the patient already had a head injury, a patient already had significant comorbidities, so a surgery was not offered, as well as the patient attendants were not also keen in doing for a surgery. This was last year when we had this case. Did a balloon dilatation, some amount of improvement for 15-20 days was there, but again, after 15-20 days, we are again back to square one. So in this patient, it was a decision that was taken to put a silicone stent, and then let's see how the course of illness remains after putting a silicone stent. So a silicone stent can only be put with the help of a rigid bronchoscope. Through the rigid bronchoscope, we decided to first dilate that area, because for silicone stent, it doesn't have that much amount of tensile strength that it can go into an area like a metallic stent and will self-expand. You have to create an area, and then only you can place a silicone stent. So first, some amount of balloon dilatation was done. Then with the help of the same rigid scope, we went past this area. So at least a 10-14 centimeter of rigid bronchoscope was passed through that area, that made the lumen of that area at least 10 to 12 or 14 mm. Then now there are two techniques of putting a silicone stent. One is you put it with the help of a deployer, which comes with silicone stent, where you are doing it blindly. But another technique is you can fold your silicone stent, hold it with the help of a rigid bronchoscope, and with the help of your flexible scope, you can see the entire process under your vision. As you can see here, this forceps is holding the silicone stent, going inside the rigid barrel, leaving it at the site of obstruction, and then with the help of your flexible bronchoscope, you are able to check and see whether this placement has been done properly or not. So again, not just blind, you can just fold a scope and can do with the help of this at least straight tracheal and bronchial stents, not with Y stents. With Y stents, you have to still use a deployer to deploy a Y silicone stent. So coming to recommendation, stent placement should be done if all other treatment modalities have failed and the patient is not going to be a candidate for surgical management. Regarding this case, which we have done a silicone stent placement last month, we have removed this silicone stent and it's been almost a month. His airway lumen is intact. So after a 1 year trial, this patient was not having any symptoms. So we gave him a trial of stent-free interval because our guidelines also says that 6 months to 1 year, you should try to remove the stent and then see if the patient area doesn't collapse, it doesn't form enough granulation tissue, doesn't cause narrowing. You can ask the patient to live freely without a stent in situ. Coming back to my case number 2, this is the last video which I'm going to show you, and then we'll log off with today's presentation. I'll be taking up your questions. So as you remember in case number 2, when there was a Bangladeshi patient who had a subcarinal mass, who had a right middle lobe bronchus being narrowed and a right lower lobe also showing you a narrowing because of the extraluminal component. This is just last week we have done this case. So in this patient, when you know that in right middle lobe, there is an opening which is narrowed because of the tumor, that was one. Second thing, you know that in this patient, in right middle lobe, there is a big mass also in the right middle lobe, which is involving the right middle lobe parenchyma. So attempting to achieve everything should not be the aim of intervention. In this, if I thought that I'll debulk this tumor and then I'll put a stent here also, would not have been a justified choice, because I know there is a tumor in the right middle lobe itself also, not just in the bronchus, but in the parenchymal part of the middle lobe also. So what we decided, we'll just take biopsies from this part so that we have a diagnostic approach. So we take few biopsies from the right middle lobe, but the right lower lobe patency was almost going because of this extraluminal component. And as we discussed, the extraluminal component has to be managed with the help of a stent. So we decided to put a small bronchial stent in this right lower lobe bronchus. And thankfully, we were able to successfully place a 2 centimeter bronchial stent in right lower lobe with the middle lobe left intact as such. So this is the stent which is going in the right lower lobe bronchus. And as you can go through the stent, you can see that yes, the airways of the right lower lobe are patent. And this stent in itself, when it came out, obscured the right middle lobe. So some part of right middle lobe got obscured because of the stent. But again, our aim was not to achieve everything in life. Our aim is to achieve a significant patency. So significant patency of right lower lobe as well as right upper lobe is achieved. Left lung is reasonably fine. So the patient is now being posted. The patient has already gone for chemotherapies and at least one cycle of chemotherapy is already been done. Plan is to keep this stent for at least 3 to 6 months. If the patient shows significant response, because again, small cell carcinomas are a good responsive tumor as far as airways are considered. If it shows a response, we'll definitely remove this thing. So coming to the algorithm, if you have a malignant central air obstruction who's a non-surgical candidate, endobronchial tumor, debride it or debulk it. But if it is an extraluminal component, do a stent placement. And we suggest that better is to do it under rigid bronchoscopic guidance with the help of general anesthesia. If you have a non-malignant airway, if a patient is a surgical candidate, always go for surgery. There is no role of intervention pulmonology if a person is a surgical candidate. If he's not a surgical candidate, try to dilate, try to excise if these kind of webs are there, ablate these kind of webs or granulation tissue, whatever is forming. If these therapies are not failing, if these therapies are giving you a recurrence of the disease, then yes, a stent placement should be considered. But again, also here, choose rigid bronchoscopy, choose general anesthesia, and maybe after a period of 6 months to 1 year post stent placement, you can try to remove this stent and see how your patient is behaving. So following all of your guideline perfectly is like trying to follow your GPS that keeps recalculating. But at some point of time, you need directions, you need things which can tell you, or you need to go beyond your guidelines also. So always try to follow guidelines, but again, each case is going to be different, and that only can be handled when you start practicing more. And if you have any doubt, start asking people who are doing these things routinely on a routine basis. So with this, I'll finish my presentation. And if there are any questions, I'll be happy to take them.
Yeah, thank you so much sir, for your nice and brief presentation. Sir, there are some questions in the chat box.
Okay, I'll see the chat box then. Okay, there's a question. Central airway is defined as at least 50% luminal obstruction, but grade 1 is 0 to 50. So again, there is always a debate regarding the definition of central airway. Certain people or certain guidelines, they don't consider lobar bronchus obstruction as central airway. Certain guidelines, they take 50%. Certain guidelines, they say that less than 50% can be considered as a part of grade 0. But any obstruction in the airway, especially these major airways, is a part of central air obstruction. Some guidelines have quoted 50, some has even taken less than 50. So, in lack of any standardized definition, we keep everything as central airway and just give them a grade. The grading part is to facilitate your intervention, which you are planning to do. Whether you actually need to do an intervention in these patients or not, that is going to be decided by this grading. There are another gradings also. Certain gradings are taking it as grade 0 when you have less than 50%. So again, different guidelines and different authors have mentioned this thing in their own manner. I think so there is a now hard need of guidelines coming up for us, which have a standardized protocol and which have a standardized definition as far as these patients are considered. Coming to another question. Okay, role of bronchoscopic endobronchial brachytherapy, a upcoming modality for your central airway tumor. So the person has asked me the role of bronchoscopic endobronchial brachytherapy. If you have a tumor in the airway, which is not causing a critical airway narrowing, you can definitely, and you know the tumor is going to be responsive to radiotherapy. You can consider an endobronchial brachytherapy. A few of the cases we have done when we were working at All India Institute of Medical Sciences, where our radiation team used to call us, where with the help of our bronchoscope, we used to go and place their catheter into that particular tumor. But slow modality takes time and critical airway narrowing should not be there. Because sometimes what happens if the patient is having 50-60% of airway involvement, as soon as you give a brachytherapy, the tumor is going to swell. Because post radiation, there is commonly a swelling which happens in the mass lesion. That can make this patient a critical airway. So for small tumors or for tumors who are distally located, where you can't do an intervention, where you can want to try a slow modality, and these are radiosensitive tumors, yes, a bronchial brachytherapy can be considered. A lot of data is being done, a lot of trials are being done on this brachytherapy, and very soon in future, we'll have definite answers on which tumor should be approached with this modality and which tumor should be directly approached mechanically the way an intervention pulmonologist is doing. Okay. So there is a very good question. What are the ways to suppress cough in diagnostic bronchoscopy if you don't want sedation? See, I would say ideally every patient should be done a bronchoscopy under sedation. It's a very distressing feeling for a patient to go undergo a bronchoscopy without a sedation. It's not a very comfortable feeling. You don't want to spoil the experience of a patient by not giving him enough sedation. If there are absolute contraindication, you can't give a sedation to a patient, then properly nebulizing them with lignocaine, giving them enough amount of lignocaine sprays, and spraying as you go during the bronchoscopy is a good enough technique to take care of the cough. Some people even prefer transtracheal instillation of xylocaine, which have take care of their airway. Some people even do this nerve blocks also, which takes care of the cough. So it all depends on the expertise you have. It all depends on the expertise your anesthetist have. There are certain institutions which I have heard, which I have recently learned that they give a nerve block, and giving a nerve block suppresses the cough entirely. So a nerve block, if can be given, suppresses your cough. Xylocaine sprays as you go, you instill xylocaine. Xylocaine being pushed into the transtracheal area or transtracheal approach are some things which can take care of your cough. But I would recommend, especially for interventional pulmonologists who are doing therapeutic interventions in these patients, a definite backup of anesthesia and a good sedation and a good analgesia. If you give, your procedure is going to be very comfortable for your patient and equally for you also. Coming to, okay, there is a very good question, sir. What are the views of drug-eluting stents? For cardiac patients, I think so they have a good enough data to tell us that drug-eluting stents are going to be a beneficial thing. For our patients who come with lung cancer, where I'm thinking that a company comes up with a drug-eluting stent where a chemotherapeutic drug is being given to that, would be a good choice as far as future is considered. There is not enough data as of now to support that for every patient a drug-eluting stent is done, because as of now intratumoral chemotherapy has not achieved its stand as far as management of these lung cancer patients are considered. So drug-eluting stent basically means when you are giving intratumoral therapy. So as of now, there is a paucity of data as far as intratumoral chemotherapy is considered. It has not yet been recommended that every patient who has an endobronchial disease should be given an intratumoral chemotherapy. Once we achieve that data that intratumoral chemotherapy is a good modality, then yes, if companies come up with these drug-eluting stent where you can give cisplatin, paclitaxel kind of drug, intratumorally, it is definitely going to be beneficial because you have an airway narrowed, which you have taken care of with the help of a stent. If the stent is going to elute the drug, if the stent is going to reduce this, you can say, the burden of the tumor, definitely your patient is going to be beneficial with that modality. Obviously, you are going to do a systemic therapy also, but suppose if the patient is not fit for a systemic therapy, then that stent which you have placed might help you by giving that tumoral anti-tumoral drug at that particular location where the tumor was causing problem. Again, another important question: what is the definition of critical area obstruction? So, critical area obstruction you will call when the patient is having more than 50%, because above more than 50% symptoms start appearing, and above 70% it becomes an absolute critical. So yes, central obstruction you will call it as above 50%, but for critical you can take 70% as the limit, because above 70% the patient becomes a candidate for intervention, and intervention has to be done in this particular patient, because now it is a time when you can't wait for patient to deteriorate further, because if it deteriorate further then it becomes an emergency procedure, and emergency procedures are always having more complication as compared to elective procedures. 70% and above should be considered as a part of critical central area obstruction. Okay, another question is endobronchial biopsy through flexible bronchoscope cause deterioration of functional status of patient if it is not followed by central airway patency maintenance intervention done along with it? I did not understand your question. Endobronchial biopsy through flexible bronchoscope cause deterioration of functional status of a patient if it is not followed by central airway patency maintenance intervention done along with it. Okay, now understood your question. So the person wants to ask me that if you have done just a biopsy from the airway, but you have not done a central airway intervention, it all depends on how much is the tumor extent in your patient and what is the histopathology of your tumor. Now, if you have a patient who has small cell carcinoma, airway is reasonably 40-50% open, and the person is not symptomatic, taking a biopsy and sending the patient to your medical oncologist serves the purpose. If your patient is having a critical airway obstruction, you just went inside, took a biopsy, and then came out and then referred the patient to your medical oncologist, that is going to be difficult for a patient to manage. So, in this situation, when you have a central airway obstruction that is critical, where the person might not become a fit candidate for chemo radiotherapy, then in that situation, just taking a biopsy is not going to do the justice. Then in that situation, along with the biopsy, you should definitely plan a definite intervention so that you improve the performance scale of the patient, you remove his misery, whatever is there, and refer him to your oncologist for further definitive management. Okay, another very important question. Do you need assistance of CTVS surgeon, echo, cardiopulmonary bypass, etc. in certain cases? Thankfully, as of now, we have not been stuck into a situation where we would have required ECMO. So ECMO, we have never required ECMO in our patients. We were able to somehow manage their ventilation and somehow able to do all the interventions in our patient. CTVS surgeon is an absolute must. Not a CTVS, a thoracic surgeon is an absolute must. You do not know when you are going to land yourself in a situation where surgery is the only answer to your intervention. Plus, there are certain situations when you are just going to do a limited job, and the remaining job is to be done by a CTVS surgeon. If you remember the case where I showed you, where I was trying to smear the right upper lobe lesion, that was actually half of the video which I showed you. This whole tumor was blocking the right intermediate bronchus also. So in first setting, I decided to remove the entire mass in one go. I was able to achieve intermediate bronchus patency, but right upper lobe bronchus was still blocked. Sorry, right main bronchus was blocked due to the tumor, and the tumor was coming from right upper lobe. I removed the tumor from right main bronchus. I was able to achieve the patency of right lower lobe, as well as I was able to achieve the patency of right middle lobe. Then I tried to debulk the endobronchial extent of that tumor. I thought I might be able to remove the entire tumor in one go and the patient might not need a surgery. But when I found that the base of the tumor was quite adherent and a broad base was there in the right upper lobe, I decided to stop at that place because the patient, as I showed in my video, started bleeding. With the help of APC, I was able to cauterize that area, and then I decided to shift the case to my thoracic surgeon who did a right upper lobe lobectomy. This was 3 years back when I did this case. Since last 3 years, the patient is coming regularly to me. He's a 30-year male. He had a tumor, carcinoid tumor, and after debulking of this carcinoid tumor, he's doing fine. Only right upper lobe lobectomy was done, which was necessity in a case. Recently had a young girl who had a tumor. The tumor was atypical carcinoid. Here, the surgery is answer to your problems, not your therapeutic intervention. So a need of thoracic surgeon is definitely there. ECMO, if you have at your center, very good, because sometimes a patient might need an ECMO support also. But again, in every case, treating an ECMO, I don't think so is the indication. If you have it, yes, it is going to be a backup for you. Guys, can you just excuse me for a minute? I'll be back in just a minute. Just excuse me for a minute. Yeah, guys, sorry for the inconvenience. Yes. So again, CTVS surgeon is an absolute must. ECMO, if you have, then it is good. Cardiopulmonary bypass, if you have, is good, because if a patient deteriorates on table, if you have this backup, you can at least take care of the oxygenation and ventilation and everything of the patient. Coming to next question, what are the bronchoscopic modalities for organic foreign body removal? Is there any role of Dorme basket in it? Yes, absolutely. If you have an organic foreign body, if you have a basket, if you can able to hold the foreign body in your basket, it is the easiest thing to remove your foreign body. Cryo, it seems good, it seems lucrative, but again, a good control of cryo is needed, because sometimes what happens, your cryo probe even stick to the airway mucosa, and when usually these patients are kids, and when you try to remove it, they avulse the mucosa of these patients also. So again, dormia basket, even a plain biopsy forceps, a biopsy forceps, you hold the two organic foreign body, you bring it out. That is the easiest thing you can do with these patients. You don't always need the cryo, but yes, if you have a cryo, if these foreign body are not being held with the, what I try is with the foreign body, with the forceps I try, with the dormia I try. If after that I fail, I usually do it with the help of a cryo probe, where I know that organic foreign body can be easily removed. Factors of good and poor outcome in critical airway obstruction. I think so. The most important factor is your expertise, availability of everything at your center. Then diagnosis of the patient. What is the diagnosis of the patient? If a patient is having a carcinoid, if a patient is having a benign tumor, if a patient is having a benign stenosis, definitely the outcome is going to be good. A patient with an ECOG 4, a patient who has an aggressive tumor, small cell carcinoma, involved the area significantly, cardiac patient, already have renal issues, moribund patient, nutritionally very weak, is going to have a poor outcome. Plus, lack of available resources, not having a rigid, not having cryo, not having APC, going inside, doing tumor debulking, not having an OT setup, not having a dedicated anesthesia team to take care of all the ventilation while you are doing all your stuff. So I'm blessed that in the last 4 years, I have a dedicated anesthesia team who takes every case as a challenge. And while I am the one who is doing all the interventions, or my team is the one who is doing all the interventions with me, they are the ones who are taking care of all the ventilation, oxygenation, hemodynamic monitoring of your patient. So saying that I, as a alone pulmonologist, can do everything, or our pulmonology team was alone able to do everything in case of central obstruction, is going to be entirely a false statement. You need a dedicated critical care team to take care of your patients pre-procedure, post-procedure, and you need a good anesthesia team to take care of the patient while you're operating these patients. Coming to another question, during the procedure of placement of stent, if the bronchial swelling does not get relieved and it increases further, how do you plan to manage it? So if you are putting a stent in a patient where there is an extraluminal compression, you will be able to put it. You won't have the issue of bronchial swelling at all. If there is a bronchial swelling, intrinsic swelling in the airway, the stent has such a tensile strength that it can take care of the lumen, or it can adjust according to the lumen. If you have put a stent, you want to say that if the stent has not yet opened properly, you can do a balloon dilatation within the stent, so that stent takes care of its shape. Sometimes it takes certain hours for the stent to achieve that patency. During that time, you can keep nebulizing the patient. During that time, you can keep giving steroids to the patient, and balloon dilatation mechanically at that time and maybe next day sometimes helps you in taking care of the bronchial swelling. If bronchial swelling is due to that malignancy, then practically stent is gonna be an answer that it can take care of the malignancy also. But if there are big tumors which are sitting in the airway and you just put a stent in that, there might be a possibility your stent might not open up to the extent to which you have wanted it. In those cases, you might need a debulking of those tumors before putting a stent. So for stent also, you need certain lumen, especially if you have an endoluminal disease. If you have extraluminal disease, then yes, stent can be put, because extraluminal disease can be taken care of by a stent in a proper manner. But with endoluminal disease, sometime a debulking into those tumors needs to be done and significant luminal patency needs to be maintained. Then only you are gonna put up a stent. And sometime even when you have achieved a very good patency by doing the endobronchial debulking, you might not need a stent at all. So at patency of airways achieved, you need stent when you have extraluminal compression. Usually for endoluminal things, you can just debulk them and take care of these things. But again, balloon dilatation is something which helps you. Nebulization is something which helps you, and your steroids is something which helps you in taking care of this. Okay, there is slightly an non-related question to this talk. Lung volume reduction surgery increased lifespan in end-stage COPD patient. Yes, if you see the trials which have been done for LVRS, they showed that yes, LVRS improves survival, improves overall quality of life as far as patients are considered. Although in India, nobody is doing LVRS. People are moving in interventional pulmonology branch from LVRS to BLVRS. So BLVRS is going to be something which is going to be there with us in the next future. But yes, if LVRS done for a proper indication for a proper COPD patient has been found to have an increased survival, increased improvement in quality of life of this patient, provided it is done by an expert person, because it again contains, or it again has associated significant mortality also. So that was the primary reason why this thing could not pick up in a proper manner. And now, to bypass our surgeons, we pulmonologists have brought this concept of bronchoscopic lung volume reduction surgeries, for which coil, valves, bronchial thermal vapor ablations are being done in the country. And very soon, in the next few years of our practice, we'll be most likely giving these opportunities to our patients of COPD whom we have medically exhausted all the treatment. I think if there are no more further questions, if there are any further questions, one or two questions, we'll be happy to answer them.
I think we are at the end of the session.
Okay.
Since there are no more questions, so very much thank you, Dr. Saurabh Pahuja, for sharing your valuable insights and expertise. At Lupin, we remain committed to supporting the learning journey of young and upcoming pulmonologists through multiple initiatives on SkiFlix, and we look forward to bring you much more series in the upcoming lectures. Once again, thanks everyone for joining us today. Thank you so much.
Thank you, Abhinav, and thank you to the entire team of Lupin. And just a last message that now, from now onwards, every Friday you will have a masterclass like this. And very soon we are going to come up with an announcement, maybe that with partnership with Lupin, we are going to start up a series, especially for our young minds, where they can come up, where they can listen to almost, not almost, I would say, the entire pulmonology, critical care, sleep medicine interventions in this every Friday class being taken by esteemed faculty from the country. And this is going to be helpful as a part of your postgraduate course journey, as well as if you are planning to prepare for your DM super specialty programs, you can come and see these lectures. So from now onwards, every Friday you will have, and very soon in next 1 or 2 weeks, we'll come up with this formal announcement of this proper prep series where postgraduate residency and exit exam and preparatory series will be started in partnership with Lupin on this SkiFlix platform. So tune up to this site, and Team Lupin will be very much in contact with you in telling you every time about what are the lectures, what are the schedule of the upcoming week. And we'll be more than happy if you attend these lectures live, although there will be recorded version of these lectures also, because in live class, you always have the advantage of asking questions, whatever comes to your mind. So thank you very much, everyone, for a patient listening, and hope to meet you frequently during these master classes.
Thank you, doctor.
Thank you.
Yeah, thank you so much, everyone. So from here, I'm closing this meeting. Thank you.
Thank you.